Hello, this is Larry Baddour. I'm a professor emeritus of medicine at Mayo Clinic Rochester in the departments of medicine and cardiovascular medicine. And I'm here as the chair for an AHA science advisory entitled Percutaneous Mechanical Aspiration in Patients with Right-Side Infective Endocarditis. I also have Abdallah Sabbagh here and ask him to introduce himself.
Thank you so much, Dr. Baddour. My name is Abdallah Sabbagh. I'm an associate professor of medicine at Mayo Clinic in Florida, and I'm an interventional cardiologist as well with interest in percutaneous mechanical aspiration. The landscape of endocarditis has changed over the recent years. We've been seeing that the epidemiology has changed, where patients have become more complex. They're higher risk for the conventional therapies of endocarditis, which is basically surgery if they don't respond to antimicrobial therapy. And so percutaneous mechanical aspiration has emerged as a treatment option in these patients. And the goal of this technology is it uses aspiration devices that were intended and initially designed to aspirate thrombus in pulmonary embolism. And so these same procedures have been used on the right side of the heart, on right-sided infective endocarditis, to aspirate vegetations with the intent to clear the infection or disrupt recurrent embolization. And this has been done, and this procedure has increased in its use, and it's been done differently in different centers. And so the procedure has gained a lot of popularity recently. In fact, it made it into the European guidelines in infective endocarditis. So we intended through this advisory to, one, clarify the rationale and evolving indications for the aspiration in right-sided infective endocarditis, and to review the current evidence and procedural considerations, as well as provide expert consensus on patient selection, device use, and procedural safety, and then identify ongoing uncertainties and research priorities and opportunities. So maybe Dr. Baddour, do you want to touch base or discuss the rationale? Why do we need a percutaneous option in these patients?
Yes, I mean, what physician doesn't want more options for individual patient management? PMA, percutaneous mechanical aspiration, represents an option in select patients. We have to remember that right-sided infective endocarditis, which can occur in two populations: people who inject drugs, which are the majority of cases, and older patients with CIED infection. These are the two populations where PMA will largely be used. One comment about PMA, it's been utilized for over 10 years, and we felt like it was time to bring forth a science advisory from the American Heart Association so that there would be this perspective presented by the AHA. And we really appreciate the opportunity to be able to do this. Getting back to the infection, it's right-sided infective endocarditis. Unfortunately, Staphylococcus aureus is a major player in this syndrome, both in the people who inject drugs and those older patients with the CID infections. It is a very virulent pathogen and one that concerns us a lot as far as morbidity and mortality. Traditionally, Staph aureus as a pathogen is accompanied by increased mortality risk. So it's very appropriate that we look at this now that we've been doing PMA for right-sided infective endocarditis for over 10 years. I think, where it's used for these select patients, it's usually used as a means to obtain source control. source control, so that increasing complications do not occur despite appropriate antimicrobial therapy. Surgery certainly is an option and has been there, as Abdallah mentioned, for years, decades really. But there are times when surgery may not be an option for a particular patient for a variety of reasons. And this, again, PMA represents an option for us as we address the individual patient.
Yes, absolutely. And so this is exactly why we needed this advisory. And we summarized the evidence in order for the reader to understand what the current data is and its limitations, more importantly, because it is an area of ongoing investigation. We also summarized the current available devices, the mechanism of use, the different types and the subtleties between each device. And then we also put in a framework to help to help the reader understand the workflow that's needed to make decisions in PMA. And we basically summarized that framework as debulk. D, which is discuss candidacy and the role of the endocarditis teams. E, to evaluate the vegetation and its anatomy. B is the best timing, the timing of intervention. U, to utilize the optimal devices. And then L, leverage the optimal technique. And then finally K, which stands for keep monitoring. So what to do after the procedure. And this hopefully will, as this procedure continues to evolve and to be in increased use, this advisory will hopefully help the reader, whether it's the interventionalist or the non-interventionalist taking care of these patients, help understand what the data is, what the framework, and to start aligning the thinking process and the approach to these patients. And we also finally concluded in this document what the next steps are, which ultimately is a clinical trial and prospective data needed. So we hope that you find this document useful when you're taking care of patients with infective endocarditis, and hopefully it'll also summarize what would be the next steps in future directions. And Dr. Baddour, anything else from your standpoint?
No, I think we've covered the important points. Again, this represents an option in select patients. For going forward, we do want randomized clinical trial data to establish efficacy and safety. But currently, turning to the endocarditis team, multi-specialty team, and determining whether PMA is right for the individual patient is where we are today.
On behalf of the writing group, myself and Dr. Baddour, I would like to really sincerely thank the HA team for giving us this opportunity and for supporting us through the whole process, especially Dr. Barb Antel and Julie Eisel, who have been extremely supportive. And again, thank you so much, and we look forward to this being published, and hopefully, again, that the readers find it useful in their practice.